Hi, my name is Dr. Jennifer Beck. I'm an orthopedic surgeon here at UCLA Health, specializing in pediatric sports medicine. I want to welcome you today to our three-part webinar talking about ACL injuries. First of all, I'm going to start out talking about ACL injury and the diagnosis and talking about the treatment options. Next, one of the UCLA Health physical therapists, Carol Netter, is going to come in and talk about the rehab aspect of the post-surgical ACL reconstruction. We're going to finish this webinar talking with Dr. Doug Polster, who's our sports psychologist. He's going to talk to us about return to sports, fears and anxieties, and coping strategies, and how we can maximize getting our athletes back to play. So I'm going to start first of all talking about the initial diagnosis, what the ACL is, and some treatment considerations. Couple objectives that we're going to go through as part of my talk here is about the epidemiology and risk factors of ACL injuries, talk about the anatomy of the ACL and what it even is. We're going to go through a couple of history and physical exam findings, and then we're going to go into briefly the non-operative management as well as the much more common operative management of these injuries. First of all, most people here, if you're watching this, you've known someone, you personally have had an ACL injury or tear. We all know it's a big epidemic that's happening, especially in youth sports right now. It is the #1 surgery I do as part of my operative youth sports medicine practice. About a third of knee injuries in soccer players in this preteen teenage year will sustain an ACL tear. And we know if you present to our clinic or an urgent care setting with a knee injury that's got a big swelling associated with it, even a half or 2/3 of these patients will have an ACL tear. So we know that this is a big problem. We're facing a lot on the medical side. Obviously, it's affecting a lot of our patients as well as their families. So hopefully you can get some good information today about how we can maximize your time with your ACL injury and your recovery. So some of the risk factors that we've known, lots of studies are looking at how we can stop this epidemic. We know that youth sports right now, patients are increasing their participation in these cutting and pivoting sports. So that's the side-to-side type of sports. Most commonly here in Southern California, that's going to be soccer, tennis, volleyball, football, and going up to Big Bear and up into the mountains doing skiing as well. So lots of sports involve this side-to-side motion. We also know all of our athletes, even starting at very young ages, are getting into intense training cycles with multiple coaches, multiple teams. The pressure on these kids is tremendous to keep participating. And we do have several very good studies out that are showing this increase in sports participation is increasing the rate of these injuries and injuries in general. Lastly, we do know that there are some biomechanical factors of just anatomy, how lower extremities are developing in kids, some of the differences between males and females, the size of their ligament, the position of their knee, their hip, their ankle. There are some just baseline anatomy risk factors that these young athletes have, particularly females, that predispose them to have these injuries. We are doing ongoing research looking at all these risk factors to see how we can modify them and potentially prevent some of these injuries. So when you look in what is the history in physical exam, some of these things that we look at on the medical side so that you patients as well as parents know what's going on. You may have athletic trainers at your school that you see on the sidelines or on the field examinations. What are they doing? What are they looking for? What kind of questions are they asking your athlete or you if you've been injured? The most common way that people tear their ACL is actually a non-contact injury, is that an athlete's going to go one direction to chase after that ball and suddenly twist and change directions. It's usually not a big contact impact when you think of football type collisions. It is much more common that someone just goes to change directions and they fall down. Seems like a very benign injury, but it actually can do a lot of damage. We know that very soon after with this type of injury, swelling happens in the knee. And the two main things we think about on the field and in the clinics and in the urgent care is this ACL tear or having a kneecap dislocation. That's another big possibility. Most of these patients are able to do some walking off the field. They may feel like their knee's a little bit weak. The big thing is this swelling and some dull, achy pain that happens. Those are all things that your athletic trainers are looking for, and you as parents of young athletes should be looking for as to how urgent this is to take your child into a clinic. So what is this ACL? So anterior cruciate ligament is what ACL stands for. Anterior just means that it actually attaches in the front part of the knee, on the front part of the shin bone. Cruciate means that it's a crossing type ligament because it goes across in a side-to-side trajectory, as you can see that's highlighted in this yellow circle. Then ligament, lots of confusions about what's a ligament, what's a tendon. So a ligament is something that connects two bones. This particular ligament connects the end of your femur or your thigh bone to the top part of your tibia or your shin bone. And we know that it's deep inside the knee, so it's not something you as a parent or you as a patient can go and touch and try and feel, did I tear my ACL? You won't really be able to poke and find it because it's deep within inside your knee. The two main things that this does is this stabilizes your knee from a front to back motion and also from a rotation motion. We know that the tears cause this weakness in this knee that over time can cause more damage. We're going to go into that in a few slides later. The big thing that it does is it controls the rotation and the side-to-side motion. That's the frustrating thing for a lot of people who have these injuries, is walking straight forward, walking up and down stairs. Day-to-day activity with an ACL tear is typically pretty easy and pretty asymptomatic. The problem becomes when you do twisting motions, getting in and out of cars, playing sports, doing those types of things is when you'll notice that ACL tear, not in just your general day-to-day motion, walking up and down stairs, walking through a hallway. So if you go into an urgent care setting or into a clinic, most often we're going to start getting some x-rays or some radiographs. The couple things that we have to look for and make sure is that there's not any broken bones, which could also mimic themselves as a big swollen knee. We also want to see, is your child done growing? Do they still have growth plates? Those are things that I, particularly as a surgeon, pay a lot of attention to. And then lastly, we look at alignment, how the hips and the knees and the ankles all line up over each other. That's something that tells us some of the risk factors as to why this happened to you, and if there's anything we can do to try and modify that and prevent this from happening again on that same side, or, God forbid, on the other side, that you ever have an injury on the other side. X-rays are really good at showing bones. The hard thing is they don't show the ligaments, the cartilage, the meniscus, those types of things. You don't see those on X-rays. That's why we have to go ahead and get this MRI, which is a very special test, very easy, just lay down in a machine for a few minutes, and it gives us very special pictures of all of those ligaments. Not only do I want to look at that ACL, but I also want to see if there's any damage to the cartilage on the outside of the bones. Was there any meniscus damage? The meniscus is a shock absorber cartilage that sits between the two bones that is very often injured at the time of an ACL injury, and that's something that may also have to be addressed in the future. Also on that MRI, we can take a look at the growth plates, and that gives me another idea as to how much more growing your child has and potentially what options that we have from both a non-operative and operative management standpoint. So you come in, your child's been diagnosed with an ACL tear, you've been diagnosed with an ACL tear. What are your options? So non-operative management of an ACL tear is something that can be done. Sometimes we have to purposefully not operate on patients because you have other injuries, other ligaments. Not every ligament in the knee needs surgery. So sometimes if you've injured more than one ligament, we actually need to get the first ligament to heal before we can address your ACL injury. Really, non-operative management is reserved for those patients who don't have any other meniscus or cartilage damage, anything else inside the knee that could be worrisome that I'd want to address and fix as soon as possible for you. Back when we didn't have the great surgical techniques that we have now, non-operative management for young patients aged 9, 10, 11 who had a lot of growth remaining was the mainstay of treatment. The fear was that us as surgeons were going to do something to those growth plates and potentially alter how the legs grow or the angle of the legs. And so we as surgeons were very fearful of doing ACL reconstructions. Technology is much improved over these last 15 or 20 years, and now we have great surgical techniques that help us avoid that. So now delaying reconstruction just based on age is not something we do as often, but it is something to consider. The hard thing with non-operative management, particularly in our young athletes, is that you have to tell them there's things they can't do. They can't play soccer, they can't play football. The twisting sport side to side, that is something they're no longer able to do. Every time they do those twisting type motions, there's a chance of more damage in their knee. And some of that damage is irreparable damage that we don't want to start. And if there's anything we can do to prevent that, then we'd have to do that. It's also very difficult because there's no special brace that I can put a patient in that will stop those injuries from happening. And so a lot of times we rely on our rehab specialists, our physical therapists like Carol Netter, to try and maximize their strength, maximize their quads, maximize their hamstrings so that we can get their knee as strong as possible. But no matter how strong we get them, it's still not going to make up for the fact they don't have a ligament. It's very hard to tell these children, young adults, not to do these activities, and we know compliance. Patients just don't listen to us. They're going to go play capture the flag with their friends. They're going to play some beach volleyball with the weekend on 4th of July. It's hard not to do those fun things. So it's a difficult treatment option for most people. The biggest risk, as I mentioned, is that going through non-operative management is every time that knee moves or shifts or has some weakness, you do more damage. And we have lots of studies that show that damage accumulates over time, which is what leads to arthritis. Arthritis is something we know is very prevalent, and you think of in older populations, our grandparents, but some patients even in their 20s and 30s get arthritis that's very debilitating from these injuries. We do know that the longer time goes on with this ACL tear, the less likely I as a surgeon am to fix any tears or damage that's happened, which is why we're typically eager to get patients into the operating room to stop any further damage. So the main reasons that I tell my patients of why they should consider surgery for this. The first thing is these kids and young adults and athletes, they want to do these sports. They typically are athletic people. They enjoy that. It's part of their life. It's part of their social circle. And in order to get back to their sport, they have to have this ligament. As I mentioned, it controls that rotation. And if you try and go and run that route as a wide receiver and you don't have an ACL, you're not physically going to be able to do it, and you're going to risk doing more damage. Then, as I've mentioned, preventing further damage is that we are developing scientific techniques for these meniscus tears and these cartilage tears, but we're just not there yet for being able to fix every single one of them. So prevention really is the best thing for this cartilage and meniscus damage. And then lastly, there are some patients that may have had an injury a while ago, didn't know they tore their ACL, and they have those symptoms just day to day of feeling like their knee is weak, it's not strong, they can't do things that they want to do. So in those patients, you're actually reconstructing them so they can get back to their normal day-to-day activities and get back to their normal life. So some of the things, if you're considering surgery, that you should go through and just think about as your checklist you should talk about with your surgeon is your knee ready for surgery? We've known in the past that we used to diagnose these ACL tears and do surgery on them very quickly to try and get athletes back on the field as fast as we can. We know that there's some risks that come with that and some increased complications after surgery. So now a lot of patients will go through an initial rehab phase before their surgery. We actually call it an ACL prehab, so preparing you for your surgery. Me as a surgeon, what I'd like to see as ideal situations is that your knee doesn't have any more swelling in it, that you have full range of motion, so you're bending, straightening, exactly the same as the other side, and that some of the muscle weakness that happens with injury has gone away and you have near full muscle strength. Ideally, I'd like to see that injured side as close to your normal side as possible in order to get you ready for surgery to minimize all of the complications you could have after surgery. One of the things, particularly in our young athletes, we take care of and pay attention to is this idea of skeletal maturity. We all ask our adult patients what their growth is, and we ask parents how tall they are, how tall family members are. If we have a younger child who's 9, 10, or 11, we're trying to see how much growth potential they have. Additionally, we know that girls usually start a growth spurt a little bit younger than the guys, somewhere around 10 and a half, 11, and they complete their growth by about age 14. We also talk about menarche status, as to have the girls started having periods, what is their reproductive health, because that's all related to their bone maturity as well. Boys, we know, develop a little bit later and start that growth spurt somewhere around 12 and a half and complete their growth around 16. So they stay with these growth plates open longer than the girls do, which may alter the treatment for a 13-year-old girl versus a 13-year-old boy. They may get completely different surgical treatment because of that growth status. Why it's so important is that as your legs are growing and getting longer, the majority of your growth in your leg comes from your knee, around the distal femur, so the end part of your thigh bone, or the proximal tibia, which is the top part of your shin bone. The majority of your growth comes from those growth plates, particularly at the end of your skeletal growth cycle in those teenage years. I, as a surgeon, don't want to do anything that's going to affect that. I want you to have a straight, perfectly symmetric limb. I don't want to affect that, which is why we're so careful with this. Because of this, we know that the concern for surgeons not having any problems or injuries to these growth plates, that's been something that many years ago we just avoided surgery for. Over the last 15, 20 years, we've developed great surgical techniques that allow us to avoid any injuries to the growth plates, so that now that's less of a consideration. Now we know that that 8, 9, 10-year-old athlete isn't going to listen to us. They're still going to go play tag. They're still going to go in those bounce houses. That we have techniques now that allow us to give them a strong knee to prevent that damage so they can go out and play, have fun for decades to come. So some of the questions, if you're meeting with your orthopedic surgeon, that you should talk to them about your ACL reconstruction is my child done growing, and how do you know? What factors are you taking into consideration? We went through a couple of those, so hopefully you can ask those questions. Is there anything else I can do to prepare myself for surgery? Do I need to do just a home exercise program, or can I go to a physical therapist or a strength and conditioning coach to help get my knee ready for surgery so I can minimize my complications after surgery? What are you going to do with this injury? ACL tears are a very interesting thing, is they're not like the skin. Once they tear, we as surgeons can't just sew them back together. We actually have to make a brand new one for you. So an important question for your surgeon is, what are you going to do to make this new ligament for me? Very common options are using these two terms called autograft or allograft. Very briefly, an autograft is when we take tissue from that same knee and use that tissue to make your new ligament. The second option is allograft, which is when someone has passed and donated their tissue. It's readily available in the operating room and used for a lot of other orthopedic surgeries. It's much faster and easier. But I will caution you that especially in young patients, and I'd say young as patients are under even 40, in their 30s and even younger than that, allograft patients who've had reconstructions with them do have a higher failure rate and a higher need for subsequent surgery. So if your surgeon's discussing using allograft, make sure that you know why they're doing that. Is there anything else you can do to prevent complications and prepare yourself for surgery, and any other type of bracing, any other instructions that you should have? And I think then the most important thing that I always try and address with my patients is, how long is this process? How long am I going to be out of sports? Not only is it the fact that you have an injury that may require surgery, when am I going to get back to be with my friends doing all of those fun things? So make sure you have a clear timeline about what you're going to expect over this next year through your surgery and your recovery. The last thing I want to mention is that this is an epidemic, and we're in the medical community doing everything we can to talk about prevention. It's a big thing right now, and there are prevention programs that can decrease chances of having these ACL tears. So talk to your coaches, talk to your athletic trainers and your athletic directors, because there are several great programs that are even up on our website that you can go through, and you can try and help with your athletes to prevent these ACL tears. In the end, this is going to be the best thing for preventing the injuries in the first place. So I'd like to thank you guys so much for talking with me today about ACL injuries. Hopefully you've learned some things about the anatomy, what to do to talk about your surgeons. This is going to be a great webinar, because now all three of us are going to come together, and our sports psychologist, Dr. Doug Polster, our physical therapist, Carol Netter, we're going to all come and talk about this initial phase of what's happened now that you've been diagnosed with an ACL tear, what some difficulties are that patients have, get you some tips and tricks about how you can maximize this first visit with all of us. Thank you very much. So now that we're done introducing the concept of ACL tears, and maybe you or your child has been diagnosed with one, we wanted to get together a group of experts here from UCLA Health to talk about all those factors that come into what just happens now that we've had this ACL tear diagnosis. I'd like to introduce Dr. Doug Polster, who's our sports psychologist, also works in injury recovery. And we've got Carol Netter, who's our physical therapist and our orthopedic certified specialist. So the first thing I want to go through is what to expect right after that diagnosis. I've just told you in that surgeon's office what happens, what exactly is going on, that maybe you need surgery. You've decided that you want to get back to sports, so you want to have surgery. Well, what do you expect now? I wanted to give you a little bit of a time frame, expectations, things from my side, and I'm going to have both Dr. Doug and Carol talk from the physical therapy as well as the sports psychology side of things, what to go through those first diagnoses days and what to expect, not only for you as the patient, but also as a family, getting back to school, getting back to work. The thing I'd like to express back is your knee needs to be ready for surgery. So if you come in having had an injury on Saturday and you see me on Monday, it's still going to be a couple weeks before the surgery is likely to happen. That's okay. We're trying to prevent complications. I know patients are anxious and you really want to get back on the field and just get all this behind you, but we go through all of these steps to make sure you have the best outcome possible. A few things to take into consideration is the day of surgery. This is what's called outpatient surgery. So you're going to come home that same day. You're not going to spend any time in the hospital. Surgery is a couple hours, depending on if any other work needs to be done, but you'll be back in your own bed that same night. Couple very important things is surgery is not everybody's favorite thing to go through. There is some pain that's going to happen as part of the surgery. We're going to do everything we can from an anesthesia standpoint, as well as for post-operatively pain medications, as well as icing, getting into your physical therapist's office as soon as possible to minimize those the pain scale that you have. I want to keep it as low as possible, but unfortunately surgery is not something that's completely pain-free just yet. The thing I do want to emphasize, it is very important to get into your physical therapist's office, even within a few days right after surgery, because there's things that they're going to do to make your life so much easier and so much better so that you can get back to school, get back to work. I just want to mention that back to school, since we are in that season now, most kids have to take a few days off of school, depending on what day you have surgery. It may be up to a week, depending on how you respond to the anesthesia, but that's something that you can plan ahead of time. You can get your school assignments, you can plan for your work assignments, make sure that your life is scheduled the best you can so that you have as little interruption as you can. And I'd like to go and talk to Carol about some of those first visits. If you've had that patient that comes in, has that initial ACL tear, their knees big and swollen, I've told them these things. What types of things do you do with them, and what kind of questions do they have for you, tips and tricks you give them?
Great. Well, the swelling, there's tons of things that we can do in the office to help. Modalities, electrical stimulation can help bring down the swelling, some taping techniques that we can help. But at home, movement to get the fluid moving, and icing. So if you have, make sure you have a couple of ice packs. One's always cold in the freezer, and one's on your knee, ready for that rotation, right? But really, it kind of can be counterintuitive, but the mobility of it, moving the knee, not weight bearing, but just bringing the knee through range of motion, can kind of seem counterintuitive, because you think, oh, I'm hurt, I don't want to move it, but actually that movement is going to make it feel better in the end, and also help get the fluid moving out of the knee back up to the heart.
So I have a question for you, because I get this all the time. People ask about how much, how often to ice. There's fancy equipment, then there's 99-cent bags of peas and corn. What is your best recommendation for icing, things that you want to make sure they do or don't do so that you're effectively using that ice?
Okay. Well, the fancy machines are set in a way that you can use more continuously. They're not going to get so cold that they damage the skin. Really, what you're concerned about is developing frostbite, which I've done to myself. So for the machines, they're really nice. So if you have access to one of those continuous pump machines that have the little igloo, it can be a nice. You can wear them almost continuously. And if you're dealing with ice packs out of the freezer, that's a 15 to 20 minute rule. So basically you're packing the knee around the front, around the back. You could use some ACE wraps from your doctor's office. If you need a couple, I'm sure they'll hand you a few freebies to secure it. And that's about 15 to 20 minutes at a time, and you want to do it once every 1 to 2 hours in terms of the frequency.
And is there any special equipment that you recommend for patients to make their day-to-day life, showering, moving around, anything easier that they can get, or just really encouraging getting back to normal life?
Most of it's pretty easy, which is a good thing. You're going to be slightly impaired, and your day-to-day impairment isn't going to last terribly long. So that's the good side of it. Showering can be a bit of a pain. Some people would like to have a little bit of a stool in the shower. So if you can go, even just going to Walmart or Target and getting a little cheap plastic stool to sit on, you're going to wrap your leg in cellophane. If you are in a position to kind of keep the open wound out of the shower, right in the first couple days after surgery, that works as well. If you want to get really into it, going to buy a handheld shower outlet so that you can sort of aim the water where you want it, keeping the leg dry, because that's your main concern in the beginning, is keeping the wound dry until it closes, right? But other than that, really, my patients aren't complaining of huge impairment, huge sense of mobility problems. One thing to think about, and we talked about logistics, right? do be prepared that you're coming home in a brace, you're going to be in pain and groggy on medications, and you're going to be using crutches. So in LA, we live in small spaces. Very few of us have tons of square footage, right? So think about it. You might have to clear out the clutter. Have an idea of your path through the house, bedroom to the bathroom. If there's a lot of stuff in the bathroom that's going to get in the way, throw rugs. You might roll up and pull out of the way because it'd just be easier with crutches, right? So visualize yourself coming into the house, walking through what would you do on a typical day-to-day basis to get your clothes. You might move a couple drawers of clothes to make things easier access for yourself. But really, the good news is that level of impairment and dysfunction is not going to last for terribly long. Couple weeks.
And I think those are great tips, because the last thing I want to hear or get a phone call is that the patient is that I just operated on fell and now we've got to see if something else happened. It's obviously uncomfortable for them to go through, nerve-wracking for everyone, and then, man, we just all worry about that. So that's really great information on the physical aspect and the impairments, but I think also things that we're recognizing more and more is the psychological aspect of these injuries. And I know from my standpoint, those visits of telling patients they have an ACL tear are very difficult, because that diagnosis just comes as just crashing down their entire life. I have a hard time, because you can just tell when I tell that diagnosis, lots of faces gloss over, they stop listening to me. And so how can we help these patients where maybe they've had family members or friends had these tears, they know what it means, that just shock, burden. What would you advise for them from the sports psychology standpoint?
So first off, that's a normal response. I remember having to be out for 6 weeks from spraining an ankle, and it felt like I had torn my ACL when I was in high school playing basketball. So any time out of a sport that we love is going to shock you, it's going to upset you, it's not going to be a fun experience. And I think the most important thing is when you leave the physician's office, when that shock and awe starts to wear off, you have a conversation with your family about what just happened. And I always tell my patients to write down those questions that come up in the next following days after they've left their physician's office. Because the next step is you're going to be going to see your PT, your mind's going to be blank, and you're going to forget all those questions that you wanted to know the answers to.
Yeah.
So dealing with the shock, understanding it's normal, talking it out with your family, talking it out with your friends, and then bringing a list of questions to your PT to say, okay, what am I supposed to do with this dressing? I didn't watch the webinar from UCLA Health, so am I supposed to have throw rugs on the floor in my bathroom? Those kind of things, because it's overwhelming. And when we feel overwhelmed, our brain doesn't process information as well. And so when we're feeling calmer and when we have processed information, that's the time to take a few moments out to reflect and say, okay, what do I need to know? What do I need to plan out? And how can I make this process be a little bit more smoothly, go a little more smoothly? And what do I need to ask my physician or my PT?
Are there any resources that are out there for people who are kind of coping with injuries? I mean, this is a big devastating thing, getting a big diagnosis. Are there any resources out there or that you could refer patients to for trying to help with that?
So I think along with this webinar, we're going to provide a couple resources that I think will be super helpful for ACL tears, but also what we're going to talk about from the mind-body connection and the sports psychology side throughout this 3-part series applies to other injury as well. And the most important things I tell everybody is isolation is bad. So removing yourselves from your friends, from your family, from your sports team is never a good thing. But also, asking questions and reaching out. So the opposite of isolation, as hard as it can be, is super helpful. And the theme of injury recovery is we start to get more comfortable being uncomfortable. And I think you mentioned that, Carol, about the range of motion, right? It seems counterintuitive. And so when I talk with my patients, I called it contradictory therapy. We're going to do the thing that causes you discomfort to help you find more comfort. And that can be an oxymoron to the brain. But understanding that that's the start of the process, is getting comfortable being uncomfortable, is going to really help her to set your brain up for a recovery and to understand what you're going to go through throughout the rehab process.
And I think that's a very important point. I know I'm constantly trying to tell my patients the difference between pain that's doing damage and pain that's part of recovery, which it's a very fine line trying to decide of, oh no, this is really bad, to, okay, I'm just getting the swelling out, I'm doing some stretching, I'm just a little sore and achy, and everyone's a little different in how they perceive those things. So I think that's really great information that talking about this initial diagnosis and starting to talk about surgical side of things, the initial recovery. Now, especially from the surgical side, I only get you for a couple hours on that operative day. It is our physical therapist who, especially in those first weeks, months, get our patients off the ground. And so Carol Netter, our physical therapist, is going to come in for our second part of our webinar and talk about what you can do, what exercises to expect, what this brace and crutches is all about, and what you can do to help with that mobility. The faster you get moving, get that muscle strength getting recovered, that better that recovery is going to be. So she's going to go through some exercises and some things of what to expect now that I've completed the surgery and you're going into the physical therapy's office. So thank you so much for checking in with us on this first part of our webinar. We're going to now segue over, and we'll see you next week for Carol Netter and her talk about the rehab after ACL reconstruction.